Well, good evening, everyone. I want to welcome you to our program. Thank you so much. We're so happy to have you here. I am Dr. Angela Harris. I'm the Health Committee Chair of the National Coalition of 100 Black Women Incorporated, Metropolitan Baton Rouge chapter. So just to go over a few of the housekeeping rules, we would like for you to remain on mute throughout the program. Place any questions you have in the chat box as we will answer them during the question and answer session. We would like you to stay engaged by answering any polling questions, but I don't believe we have any polling questions actually tonight. And at the end, we'd like you to answer a brief survey. It will actually be mailed to you. So we would like you to participate in that and help us to, be evaluated and make better programs for you. So the purpose of the National Coalition of 100 Black Women Incorporated is to foster principles of equal rights and opportunities, to promote the awareness of Black culture, to develop the potential of the membership for effective leadership and participation in civic affairs, to take action on specific issues of national and international importance, and to collaborate with other persons and organizations to achieve mutual goals. The vision of the National Coalition of 100 Black Women Incorporated is to see Black women and girls live in a world where socioeconomic inequity does not exist. The mission of the National Coalition of 100 Black Women Incorporated is to advocate on behalf of Black women and girls to promote leadership, development, and gender equity in the areas of health, education, and economic empowerment. The health initiatives of our committee includes priority focus, childhood and family obesity initiative, NCBW Cancer Health Disparities Program, NCBW Metabolic Syndrome Initiative, Prevention, Decrease Mortality, Improve Health Outcomes, Access to Affordable Health Care, Culturally Competent Research, Quality of Life, Public Safety, and Crime. Now, I would like to introduce our first speaker, Dr. Desiree Dawson, and I will tell you about her. Dr. Dawson received her undergraduate degree in genetics from the University of Georgia in Athens. She then received her medical degree from the Medical University of South Carolina in Charleston. Following medical school, she completed a residency in internal medicine at Ochsner LSU Health in Shreveport. After her residency, she also completed a fellowship in cardiology at Ochsner LSU in Shreveport, where she served as chief fellow. She is a member of the American College of Cardiology and the National Board of Echocardiography. Dr. Dawson appreciates the opportunity to provide the highest care to all patients and their families. She strives to empower patients about their health conditions so they can make informed decisions regarding their health. Dr. Dawson has a great passion for cardiology, including women's health. She is excited to welcome all new patients. In her spare time, she enjoys dancing, exercising, collecting exotic jewelry, and watching professional basketball. I welcome Dr. Dawson.
Thank you, Dr. Harris, for having me. It was a nice introduction. Thank you. I'm so excited to just join in with you all tonight and just talk a little bit about controlling the cluster. So I think this is just a great initiative, and I'm so glad to be a part of it. So thank you again. I guess I should be sharing my screen. Is that right? Yeah, let's see here. Okay. Can you guys see this?
Yes.
Wonderful. Great. Okay. So my main focus for this talk is to talk more so about cardiovascular prevention as it pertains to high blood pressure and cholesterol, which is something that a few of us do struggle with, whether it be from family history, something recently diagnosed, but it is something that we have a family member maybe that might be struggling with these two diseases, one or the other. So I figure this would be something good to start the conversation off with. So here we go. And like I said, the talk is more so related to high blood pressure or high cholesterol. So that's what I'm gonna focus on. But when it comes to metabolic disease, it's a wide range of things, diseases that we kind of look into and treat when it comes to cardiovascular prevention. But for this talk, this is what we'll focus on. And more so, it's more about what it is, high cholesterol, high blood pressure, how do you diagnose it, what it causes, and how do we treat it. I'm not going to talk much about the therapy as far as the drugs that we use, therapy that we use, but more so natural ways that we can prevent high cholesterol and high blood pressure, i.e. hypertension. So cardiovascular heart disease, stroke, heart failure, and peripheral artery disease, which is disease of the legs, are all leading causes of morbidity and mortality in adults. Unfortunately, cardiovascular heart disease is becoming the leading cause of death worldwide. A few of the risk factors pertaining to this: smoking, overweight and obesity, unhealthy diet, physical inactivity, dyslipidemia, hypertension, the two that we'll be focused on here, and diabetes. There's a national survey out, and it does show 5 modifiable risk factors, meaning risk factors that we can change for cardiovascular heart disease, which are high cholesterol, diabetes, hypertension, obesity, and smoking. So these are things that we can change, that we can reduce, that we can get rid of. It's either modifiable risk factors, which are these, versus risk factors that you can't modify, which is all family related, hereditary things that we inherit, which we can't change. And you can't change your gender. So these are things we actually can make a change in. But these risk factors accounted for half of the cardiovascular heart disease deaths in the United States of people aged 45 to 79, and that's from 2009 to 2010. Now, these risk factors had a 10-year risk of a first coronary heart disease event, meaning myocardial infarction, i.e. heart attack, heart failure, more so coronary heart disease, not necessarily stroke, but heart disease. And that made up 25 to 30% in a 10-year span. Now, the good news is mortality due to cardiovascular disease has been on the decline for years. And that is great news, because we're now talking about earlier diagnosis, more aggressive treatment of these factors that I mentioned a slide or so ago, and using of drug therapy. So we're treating people earlier. We're getting people, better access to care so that we can do all the necessary tests to check your numbers, make sure everything looks okay. And if anything looks elevated or abnormal, we treat you with medications when it's necessary. So that means cholesterol medication, aspirin, ACE inhibitors, which we use for blood pressure, and other medications that we use specifically for blood pressure, as well as heart disease specifically. And also, now that we are getting people seeing more and more access to healthcare, and basically getting the word out about things that we can change in ourselves, we're dealing with therapeutic lifestyle changes. And that's things that you can do at home, things that you can change, because when you're in the clinic, it's not always physician telling you things that you should be doing, but it's a two-way street. You do what you can, and physicians can meet you halfway. I myself, I don't necessarily like treating everything with medication, but unfortunately, there's been studies done that show that medications are, in fact, some things that you have as far as disease are going to be the key points of what's going to treat what disease you have. So a lot of times you come into the clinic and, you know, we find something that's abnormal, or we find something that we feel, you know, that should be treated and can't go without treatment as far as with medications. We're going to treat it. But if something that can be done either via weight loss or diet, I myself, we're going to try that first instead of throwing medications at you. But unfortunately, there's times that you can't avoid the medications. So hypertension, quantitatively, it's the most important modifiable risk factor for premature cardiovascular disease, meaning blood pressure is the one most important factor when it comes to developing heart disease early on. So the sooner you can get control of it, the sooner the better. It accounts for an estimated 54% of all strokes and 47% of all ischemic heart disease events globally. So it's a pretty big modifiable risk factor that we always try to get a hold of. It's one of the big ones, one of the 5 factors, again, that I mentioned before, but it's the one that's as one of the most important, I would say, because there's so many ways to change it and to decrease it. So when it comes to hypertension, when we talk about that, you're like, what is hypertension? What does that mean? So when we say high blood pressure, we're talking about the force of the blood pumping from the heart. So the heart pumps blood to your body. So for example, if your heart is pumping against blood, that pressure, that, you know, it's so hard. If you can imagine you working out, right? And you have weights and you're trying to lift weights. And as your muscles build, you're lifting more and more weights, but you are straining as you're going up in weights. Think of that as pressure. As you go up in weights, your muscles build up. As your heart works against blood pressure that becomes more and more elevated, that muscle in the heart actually gets more and more thickened. And we see that on ultrasounds all the time for long periods of high blood pressure with no treatment or treatment that doesn't work. You see a buildup of muscle in the heart, and that does increase your mortality risk. So that's what blood pressure is. Eventually, even the muscle of the arteries that the blood pressure is in, let's see this picture here, that muscle around it becomes thick. And it's here, normal blood pressure, free flowing, no big deal. Then you come to pre-hypertension, and here we go to hypertension, and it's like, it's a big pressure, it's a strain on the wall, and that wall is fighting against that blood pressure to accommodate, and it thickens, okay? And this is the wall of an artery. And so when we talk about blood pressure, we talk about the top number, which is systolic, and then we talk about the bottom number, which is called the diastolic. In the top number, the systolic is measured between when the heart contracts, and then the diastolic is basically when the heart relaxes. But that's when you get your blood pressure reading, the top reading and the bottom reading, and we pay attention to both readings. So based on the American College of Cardiology and the AHA, normal blood pressure is systolic less than 120 and diastolic less than 80, okay? And so elevated blood pressure would be just elevated. Hey, we're not high yet. So elevated would be systolic 120 to 129, and then diastolic is still less than 80, okay? So when we start talking about hypertension, high blood pressure, stage 1, systolic is 130 to 139, and diastolic is 80 to 89. And then stage 2 is systolic at least 140, and then diastolic 90 and above. So if there is a disparity in a category between the systolic and diastolic, we always go for whichever one is higher. So there are times when the systolic is decent, like 120, let's say 120. And then the diastolic is 95. You're considered in the stage 2 range technically, because that diastolic is above 90, okay? So hypertension signs and symptoms. When you do have symptoms of hypertension, a lot of times we don't know what it is, and we go running to, the clinic to say, I'm dizzy, or I've been feeling tired. And there are many reasons to have these symptoms for sure. But it should click in your mind if you don't have a history of high blood pressure, or you do have a history of high blood pressure and your high blood pressure is not being treated effectively and you're on medication or so, you can have all of these symptoms or one of the symptoms. I do get a lot of dizziness. Sometimes it's medication related. You're on a medication that's causing you dizziness, but there are times when blood pressure being so high can cause symptoms. Headaches are not on here, but headaches is a big one too, when your blood pressure is high and you have headaches. But blood pressure for the most part is very silent and you have no symptoms. And a lot of people are unaware, if you're not going to the doctor regularly and you're having blood pressure issue, you don't know it. There's a majority of the time people do not feel high blood pressure. And that's why it's called the silent killer, because you don't know. And next thing you know, stroke happens. You have evidence of heart disease, you have symptoms later on in life because, you hadn't gone to the doctor to check just to get an overall checkup. So, like I said, diagnosed blood pressure, hypertension is diagnosed as at least 130 systolic and at least 80 and above diastolic, 130 over 80. That's the number. So that's when you're first diagnosed with hypertension. So in the clinic, I try to get my patients less than 130 over 80. It depends on the situation. I try not to be so strict. Older patients, patients on a lot of medications, patients that already come in with dizziness, and blood pressures aren't so very high. I try to decide on what's the best route to go. But if you're healthy for the most part, or you have a family history, or you have a stroke history, things like that, I'm going to try to get you below 130 over 80. The diagnosis of hypertension should be confirmed using out-of-office blood pressure measurement whenever possible. So monitoring at home. And home blood pressure measurement should be the initial strategy to confirm the diagnosis. So if at all possible, we check blood pressures at home because that's where you're the most comfortable. That's where, you're eating basically what you want to eat. So we want to check blood pressure then. And so when we diagnose it at home is at least 3 out of office or office-based blood pressure measurements spaced over a period of weeks. So say if if you're checking it at home, we want at least 3 blood pressures seen on different occasions, and it's either high or low, whatever the deal may be. If you're not checking blood pressures at home, and you're getting just blood pressure only checked in the clinic, then it's going to be spaced out over months. So you come into the clinic and you've been going to the clinic, frequently, never been diagnosed with high blood pressure. Well, we look back at your prior blood pressure readings, and then we see you have a trend, and we look kind of at an average. If average wise, you're above still the 130 over 80, that's considered high blood pressure over time. Even an average at your home blood pressures, you bring in a log or your blood pressures, you kind of say, hey doc, my blood pressures have been high. And I ask you, what are your blood pressures at home? Well, 160 mostly, or 150s most. Well, top numbers, 150s, 160s, that's high. Okay. I did want to touch a little bit on how to take blood pressure, because a lot of times we don't know how to. It's easy to say we go to the drugstore, put our arm in that machine and, we get it checked or whatever. So that's always a good way to do it. And I say you're relaxed and you put your arm through that machine. Your legs are not, they're flat on the floor. They're not crossed. You're sitting straight up and you're relaxed. You're not talking to anyone. Always say patients should avoid caffeine, exercise at least 30 minutes before measurement. Don't talk while you're trying to, get your blood pressure checked, and move any clothing. Nothing should be tight on that arm clothing wise. Should be loose garments on your arm so it's not constricting your artery or your blood flow while you're trying to get it checked. These things are going to make your blood pressure seem higher than what it really is. And you should also use a blood pressure device that has been validated and is working properly. Okay. And you support the arm. So in the drugstore, you're supporting your arm on that machine. At home, you're on a table that's almost about level of your heart, maybe a little lower, because a lot of people don't have tables like really at their heart level, but you don't want your feet dangling. You want it flat on the floor, and you want to put your arm on the table, and you want to check it with your blood pressure cuff. Okay. And you position it in the middle of your arm, and you use the correct size that encircles about 80% of the arm. So you don't want anything too large, and you don't want anything too small, but what's basically circumferencing your arm size about 80% of that cuff. Risk factors for hypertension, kind of like what I mentioned, but also if you're not exercising, physical activity, inactivity, smoking, high salt diets, being African American, Hispanics, these are reasons that, these are risk factors for you to have high blood pressure. There are also causes of secondary hypertension, and they may also coexist with other risk factors that cause high blood pressure, and sometimes it can be pretty hard to control. With the secondary hypertension, the causes for that, it's other that I didn't put on this list, and those are, medical diseases that require you to like see endocrinology and get a workup and blood work. But I kind of wanted to mention like the basic ones, like a lot of us are on birth control pills that can cause a blood pressure to be high, NSAID use, ibuprofen, Aleve, steroids, stimulants, those who are taking it for ADHD or something or so. Sleep apnea can cause high blood pressure, especially when sleep apnea is not being treated. A lot of people can't deal with the masks, the CPAP machines and the BiPAP machines. And unfortunately, that does not give a good opening to treat your blood pressure correctly. Your blood pressure does tend to remain high when you're not being effectively treated for your sleep apnea. And complications of hypertension, like I mentioned, that thickening of the heart, that's called LVH or left ventricular hypertrophy. In addition, you get heart failure, strokes, hemorrhaging in the brain, kidney dysfunction. These are things that can cause complications of untreated high blood pressure. So this was just a little algorithm that I wanted to just touch on pretty quickly, but I've kind of mentioned it already when you're trying to diagnose high blood pressure. So if someone comes into, like starting at the top, if someone comes in to the hospital with really significantly high blood pressure, remember I said 130 over 80. So we're talking about 180 over 20. So that's like high. So that's, you have high blood pressure. And in the hospital or wherever you come in at, because it could be the clinic and it's this high, and not have any symptoms like I mentioned. So, but technically if it's this high, you're most likely diagnosed with high blood pressure, automatic. But if you're kind of teetering between 160 to 100 in the office, you're seeing that, and, it's coming down this algorithm saying like, do you have any other damage to, your organs, meaning like your heart disease, or you have heart failure and you're having blood pressures around this high, and you have these other diseases, well, most likely you have high blood pressure, and we'll probably give you treatment for that. But if you're not having these other diseases, then, there will go from the standpoint of home monitoring. What are your blood pressures at home? Because there are times we call it white coat syndrome, meaning you come to the office, your blood pressure is high all the time, but at home, like I said, you're relaxed and you're not nervous. You're not in the clinic office. You're not seeing all these white coats and nurses and everyone around. Your blood pressures are normal. Well, I have patients like that, and I don't go up on their blood pressures when I see their blood pressure high in the clinic. Their blood pressures are home, and we have, like, even with Ochsner, the home monitoring device. So their monitoring device, if their average at home is like normal and 113 over 70 or so, I'm not going to change the blood pressure medications. Your blood pressure is fine. What matters is with the home blood pressure monitoring. So going down the algorithm, if your home blood pressures, if the average is high, you have high blood pressure. And then I mentioned the white coat syndrome. So you just kind of go down the algorithm, and you just kind of want to know, just based on everything, do you have high blood pressure? You don't want to like put someone on medication just all willy-nilly. You want to make sure that they have high blood pressure, and doing this algorithm really does help. And it helps you to know at home, if you really do truly have blood pressure. And if you see a 1 mark spike, maybe you want to start working out and losing weight to see what you can do to help that blood pressure. And again, like, especially if it's a family history, you don't want to be, operating in, what mom and dad had or whatnot. You want to live better for yourself. And that means eat low salt, heart healthy diet, exercise more, be more active, maintain your weight. If you need to lose weight, that's the best way I tell people, if you want to get off of any blood pressure medication, lose weight. Any medication at all, honestly, diabetic medication, you can lose weight, and that really helps. Avoid alcohol use and manage your stress better, and avoid smoking. So really quickly, I'll touch on cholesterol because I don't want to spend too much time, but cholesterol is another part of cardiovascular heart disease, and we use it interchangeably. We use dyslipidemia versus hyperlipidemia. They don't always mean the same thing. Dyslipidemia means you have high cholesterol and you have a disease with that. Heart disease, meaning heart attack already, you already had a stroke, you have kidney disease, things like that. If you just have hyperlipidemia, that means you're healthy overall, but you also have high cholesterol, like your LDL is high, your triglycerides are high, and that's isolated. So that's kind of the change, but they're both lipid disorders. There's no evidence of widespread screening that leads to improved patient outcomes. So basically, we just don't screen everybody. It really just depends, especially if you're trying to know what your numbers are and you just kind of want to have an idea of what's going on. That's fine. And most doctors are not going to say no to you, but we don't screen everyone because a lot of outcomes, haven't proved to really matter overall. So, but screening for lipid disorders are important, but when it's used mostly when you have like a risk factor that you're trying to make sure, if someone say they have high blood pressure, you want to check their cholesterol because you want to see what their overall risk is going to be for any events, cardiovascular events down the line. The treatment of lipid disorders in patients at high risk or cardiovascular heart disease decreases the risk of cardiovascular events. So when you treat cholesterol, you do reduce your risk of heart events down the line, and that's been proven. And then screening, if you have no other risk factors for heart disease, then screening around 40 or 50 years old is okay. So that's why I'm saying we don't screen everyone because that hasn't proven to really change anything. For patients with higher cardiovascular risk, those modifiable risk factors, including also family history, which you can't change, lipid screening should be performed, like I mentioned before. So if you're high risk and you have those things, you do want to check your cholesterol. This just says that usually in younger adults, we don't check cholesterol unless there's a reason to. Okay, so when you get your cholesterol checked, we do like to check it fasting. And that's because, well, for example, you don't want to have had eaten sausage or bacon, and then next thing you know, your cholesterol is high, and you get mad at your doctor and you check my cholesterol when you weren't supposed to, and that was because I had bacon that day. So we like to do it fasting if possible. Times where I don't do it when you're fasting is maybe you have like a piece of toast or something, no butter or whatever. But when you check the triglycerides, that's the other thing. Triglycerides, a lot of times people have normal cholesterol, but the triglycerides are high. Triglycerides are still cardiovascular heart disease risks, meaning when I see it, it's high either because alcohol or sugar. Only two things that raises your triglycerides. And yes, it can be treated with cholesterol medication, but also it can be treated from diet change. I've seen it go down without any medication on board and complete diet change. So, and the most frequent application of the results of lipid screening is to input the data into a risk calculator. So we get the levels of your cholesterol, we put it in a risk calculator, and that tells us your 10-year risk and if you do need to be on medication for your cholesterol. We do particularly look at the HDL and the LDL. LDL is bad cholesterol, HDL is good cholesterol. And technically, when we do that risk calculator, if it's above 10% risk, you're most likely going to need cholesterol therapy, like no diet change, not like definitely diet change, but it's to the point where your risk is high and you're probably going to need medication to help you out. And if it's like a risk of between 7.5 to 10 still your risk is high. It's a little bit of a discussion there, but I tend to put people on medication for that. If your risk is below 7.5, diet and exercise. And when you do need to treat someone with therapy, it will reduce their risk by 20 to 25%. So it really does help. You want to avoid any kind of cardiovascular health disease in the future. This is just something about bad cholesterol and honestly how it looks in your vessels, cholesterol plaque here. And as they build up, what causes, and say this builds up in your heart, this, if it breaks, the thing is, as it builds, it becomes very weak. And when it breaks, that's what causes a heart attack in your heart arteries. So it's plaque, cholesterol plaque that builds up in your arteries everywhere. But specifically in the heart, when it breaks in, because it's built up to a point when it's so soft and it breaks, that's what causes heart attacks. Things you can eat and change in your diet: more unsaturated fat than saturated fat. So all the bad stuff here, and more things like avocado, salmon, nuts, beans, unsaturated, monosaturated, polysaturated. Those are good. Seed oil, that kind of stuff, olive oil. But anything like processed is not good for you. We check cholesterol every 3 to 5 years. If you have low risk or no risk, every 6 months to a year if you're high risk, and definitely being treated with something. This is my last slide. Risk factors. When it comes to women, risk factors are the same as in men, as mentioned down here: hypertension, unhealthy diet, all that. But when it comes to women, we do get stressed, family, balancing work, kids, wife, all that, and so we deal with a lot of stress, socioeconomic deprivation, psychological risk, depression, and, pregnancy, gestational diabetes. These are all risk factors. And so I always say, go get seen by a physician if you have questions, if you had any of these diagnoses, because they all relate to cardiovascular health in women. And it's important that we get checked out. And I'm done. Any questions?
Do we have any questions for Dr. Dawson? That was some awesome information.
Thank you.
Yes. I'm checking Facebook Live to see if we have any questions. Well, the one question was, is Dr. Dawson taking any new patients?
I am. I definitely am. So I don't have my contact information with me. I probably can give it. Actually, I'll find it by the end, so that we can probably put it in the chat. But yes, I am.
That would be great.
Yes.
All right. So looks like Courtney Hunt has a question.
Yeah.
She said, this was really good information. I have a question. What can you do to change your habits right away?
That's a great question. So right away, that means you kind of search in yourself on what you're not doing. And we all know what we're not doing and what we should be doing. First, I always say start with diets, because it's harder, but you can do it. So if it's eating at night, late nights, because these are things that put weight on you, right? Is it your sugar habits? How much sodas are you drinking? How much out of the carb are you eating? It should be more proteins, more vegetables, and less on the carbs, especially if you're eating out carbs. And that's, processed meats, processed foods, and that kind of stuff. So it kind of depends on where you are in your eating habits. Some people are big on fried foods and they got to cut that back. Some people are sugar lovers and it's like, oh my gosh, like I got to have my chocolate at night. You got to cut that out. If you maybe one piece of chocolate in the daytime, while you're up and about and doing stuff. And so, diet, we talked about alcohol consumption, bunch of calories in alcohol, bunch of salt and sodium in alcohol. So you got to put that to a minimum. It really, you search within yourself, because we all have what we know is the problem. And then I said, if diet is cool, everyone, diet's fine. Okay, how much are you active? Meaning exercise. And people in my clinic tell me all the time, oh, I'm active. Like, okay, you're active at home, working in the garden, but how often are you keeping your heart rate up? What are you doing with that? You got to keep your heart rate up for at least 10 to 15 minutes and then plus. And so I always say exercise for at least 30 minutes, 5 days a week, or 3 days a week for an hour, because you got to keep that heart rate up. That's the whole point. So that means exercise activity, not just active at home, but exercise. It's a difference.
Thank you.
Yes.
So another question we have from Kendra is, do wrist monitors work as well as the cuff monitors?
Yeah, I don't necessarily like the wrist monitors. I've had false readings on wrist monitors compared to the old school arm monitors, I'll be honest. They're not bad, but I honestly, I feel, because they're both checking your arteries, okay? One's checking the wrist artery, the one's checking the arm artery. It's not a big deal, but some people I guess if you do the wrist blood pressure cuff, you still lay it down. Some people raise it up, but honestly, that's not the best way. You lay it down just like you would the arm one, and check it that way. Still feet on the ground, relax, and then let it check. So I'm not completely opposed to it, but I do kind of like the old school way. Blood pressure, I feel like that's just the most effective. But I understand that people have problems finding the right size cuff. Get it, no problem. The wrist is okay.
Thank you. Next question is from Courtney McKnight. She wants to know, does eating garlic or taking garlic pills help with lowering cholesterol?
I've heard that on both ends, actually. I haven't investigated that myself. I probably need to. So that I am not sure. I've seen yes, and then I've seen it doesn't really matter. There are a couple of foods that I do know that help, like more like flax seeds, oatmeal, are big ones, walnuts. I don't know about the other nuts. Those are a handful as far as things to, eat. And I mentioned the other foods like the fish and the oil and stuff like that. But as far as garlic, I probably have to look that one up again to get like a better idea on if that's that effective or not. I think it's just uncertain on that.
Right. Okay. Janice wants to know, well, she's saying she had an extra heartbeat. Is that an indication of heart disease? She had one on her last heart cath.
Oh, I see. So extra heartbeats, it depends. It depends on, one, if you're symptomatic from it, and two, how often are you having them? Yes, it's a form of heart disease because people are labeled with extra heartbeats, meaning they're called premature ventricular contractions or premature atrial contractions. And if you're having symptoms from them, then you may need to be on medication for it, and therefore a form of heart disease. Now, it doesn't down the line cause heart attacks or nothing like that. It's all about a symptom thing. So if you came into my office and you had multiple or frequent extra heartbeats, but you weren't feeling any of them, I would not treat you, because it's all about how you're feeling. So like I said, it's not about, oh, you have them, it's going to cause a problem. No, it's more so you have them, do you feel them? And then that would mean you would need to get some treatment if you're having them frequently.
Okay. Next question. Tisha wants to know, can the keto diet increase your chances of cholesterol issues?
So over time, yes. So I don't know if I would recommend the keto for those who already have high cholesterol, because that's what you're eating in a lot of the fats that you're taking in. So I say over time is really not the best cardiovascular. Nobody should be left on the keto diet. But for a short term fix, I understand that. And we don't, as far as cardiologists, for a good reason, we don't endorse the keto diet. We endorse more like low salt diets, the DASH diet, Mediterranean diet, those type diets. But the keto diet, because of the high fat and then like technically high cholesterol foods that you're eating, we don't endorse it like that. But I mean, like I said, like for a short amount of time, sure. I mean, like, yeah, maybe a month or so, something like that, but definitely not long periods to be left on the keto diet.
Okay. Sandra wants to know, what are your thoughts on apple cider vinegar in hypertensive patients?
Apple cider vinegar, I don't have a stance on it, but I have heard that it works from people that have tried it. So I don't have a stance. There are a couple other things that cardiovascular wise has worked too. I think there was black seed oil or something. I actually looked that up, and I for a patient, and I was like, that's actually been proven not in humans, but in rodents, unfortunately, that it actually helps cardiovascular wise. And I was actually impressed with that. But when it comes to apple cider vinegar, I've had patients try it and they say that they've been doing it and feel like it works. So I'm not opposed if it works. I'm not opposed as you trying it to see if it works.
Thank you. And Courtney Hunt wanted to put in a plug that Ochsner offers digital medicine to help monitor your blood pressure.
Yes.
Thank you, Courtney.
Yes,
yes, they do.
You sure do.
You know, I have to represent for my workplace.
Yes,
right.
Thank you.
Now, I don't see any other questions, but I did want to ask something, because this is a question that I get a lot from patients.
Yeah.
They'll ask me all the time, is the systolic blood pressure more important or the diastolic blood pressure more important?
Right.
Yeah, I don't know if you get that question a lot, but how do you answer that?
They're both important. They're both important. The first thing we see would be the diastolic. Well, for me, it's the systolic. So if I see that that's high, that's like automatic. But I do pay attention to the diastolic, because patients actually do come in and say, that bottom number is high. It's weird. It's like 110. I'm like, oh God, yeah, that is high. And so that's still blood pressure issues. Like I said, 130 over 80, anything above 130 or 80, you know what I mean? So it's not just 130 that you're paying attention to. You're also paying attention to the 80. So, if that 80 is like you're 95, if you're 100, 112, like that's pretty high, and you're gonna need treatment if that overall average is above 80 and you're seeing it consistently high. But the other thing about it, I do get patients that have the high systolic and then the diastolic is really low, like 60 or 50 or something, but your systolic is like 140s, 150s. And I'm like, ugh. Treatment is very difficult because they can still run into low blood pressure because your diastolic is low. Not always do I have those patients. Actually, they're older patients when I see that. And I'm a little hesitant about what I start. I may start something, but it's probably pretty low, because more likely they're going to be symptomatic, dizzy, tired, whatever the deal may be. So I'm a little like hesitant. I try to be so strict on the 130 over 80 when it comes to them.
Well, thank you for answering that.
Yes.
Okay.
They both matter.
Yes. I end up saying the same thing. Thank you. Well, that was an awesome presentation. So much great information. And I definitely want to thank you for presenting to us and sharing your knowledge with us. And if you can find your contact information and put it in the chat at some point, that would be great. Absolutely. We have some people that want to see you.
Yes. Thank you guys for listening.
Thank you. All right. So now I will get back to my screen. Uh-oh. I think you have to stop sharing your screen.
Let's see here.
It should be at maybe the top of the screen.
It says pause share. Oh, I see. I got it.
You got it. Okay, great. Thank you.
No problem.
Okay. All right, so we've already done question and answers. And now I will introduce our next speaker. We have Dr. Alicia Bates. Dr. Bates has been a board certified family nurse practitioner since 2012. She earned both her Bachelor of Science and Master of Science in Nursing from the University of Southern Mississippi. In 2017, she received her PhD in Nursing Education and Administration from William Carey University. She currently serves as a full-time assistant professor in the Family Nurse Practitioner program at Franciscan Missionaries of Our Lady University. While Dr. Bates has nursing experience in cardiology, her true passion is diabetes. Since 2014, she has continued to practice as a family nurse practitioner in the diabetes management clinic at Ochsner Health System, where she treats and manages adult patients. Alicia is a certified diabetes educator and is a professional member of the American Diabetes Association, as well as the American Association of Diabetes Educators. I introduce Dr. Alicia Bates.
Good evening, everyone. I am so excited to be with you guys. I'd like to just say thank you to Dr. Harris for asking me to present. Diabetes, as I mentioned in my bio, is something that's truly passionate about. So I hope that you will find this information beneficial. So I'm going to share my screen. Okay, so we've been talking about controlling the cluster, and I know Dr. Dawson already kind of talked about two parts of the cluster. So she talked about the elevated blood pressure, hypertension, as well as elevated triglycerides and HDL, so the cholesterol aspect. But now we're going to transition a little bit and talk about elevated blood sugars as well as obesity, which can lead to an increased waistline. So I hope at the end of this presentation that you're able to explain the difference between prediabetes and type 2 diabetes, as well as describe maybe some prevention strategies to reduce the risk of type 2 diabetes, and also to define obesity and its effect on overall health. So currently, there are 37.3 million Americans that have diabetes, which represent the tip of the iceberg. 28.7 million of those 37 know that they have diabetes, but the other 8.5 have absolutely no clue that they have diabetes. But what's even more daunting is that there are 96 million Americans that have prediabetes. And they represent the portion underneath the iceberg. If no intervention is made or if no lifestyle changes take place, then eventually those 96 million individuals with prediabetes will transition into type 2. So they'll move from underneath that iceberg to the tip of the iceberg. So let's talk a little bit about prediabetes versus type 2 diabetes. So prediabetes essentially means that your blood sugar is high, but they're not high enough yet to be classified as type 2 diabetes. So when you check your blood sugar in the morning, we call that a fasting blood sugar. A normal fasting blood sugar is going to be less than 99. If you have prediabetes, it's going to range between 100 to 125. And the reason that you're starting to have prediabetes is because your cells in your body essentially start blocking insulin. And we all need insulin because insulin's kind of like that key that unlocks the door. So it's going to unlock the cell and allow all of that glucose that we eat to go into the cell. But if our cells start blocking the insulin, then the glucose can't get in. And eventually the pancreas says, okay, I'm going to make more insulin so that I can overcome this resistance. And eventually that pancreas makes so much insulin that it may wear itself out, and patients may go from having prediabetes to full-blown type 2 diabetes. So once we get into type 2 diabetes, we know that this is a chronic metabolic condition that's characterized by high blood sugar levels. So typically when you wake up in the morning, blood sugars are probably higher than 126. After you eat, a lot of times patients have blood sugars that are over 180s, can be in the upper 300s. I've seen as high as 500, 600s. It just kind of depends on what's going on with the patient. So we know with type 2 diabetes, there's insulin resistance. We know that the pancreas is not producing enough insulin to meet the body's needs. So there's some insulin deficiency, but there are also some other pathologic processes that can occur. For example, the kidneys. We know that with type 2 diabetes, the kidneys are reabsorbing too much of that sugar. So instead of peeing it out, it's going back into the blood vessels and it's hanging out in the blood vessels and it's causing our blood sugars to rise. We also know that the liver can produce too much sugar. And when it's in overdrive and it's producing all of that extra sugar, it causes our blood sugars to stay up. And then there's also hormones that live in our stomach that help us to make us feel full. It slows down our stomach so that it doesn't empty as fast. And then it also helps to bring our blood sugars down after we eat. But there again, with type 2 diabetes, those gut hormones may not be working properly. So then we have high blood sugars. So all of this is kind of working together with type 2 diabetes. You've got the insulin deficiency, you've got the insulin resistance, you have the kidneys that are reabsorbing too much sugar, you've got your gut hormones that aren't working right, and you've got the liver that's just putting out all of this extra glucose, and it's leading to high blood sugar levels. So some of the classic symptoms of type 2 diabetes: frequent hunger, we call that polyphagia. So these, a lot of times with diabetes, these patients, they always feel hungry, they never feel full. And the reason for that goes back to the fact that your cells are blocking that insulin. And if you don't have enough insulin there to open the cell up and put that glucose into the cell, then you can eat all of the food, but it never gets to the cell for energy. Patients also may complain of frequent urination. So in order to get rid of some of that extra glucose that's hanging out, you may start going to the bathroom more often. Well, when you go to the bathroom more often, you're peeing out sugar, you're peeing out fluids, and you're peeing out calories. So then a lot of times patients will actually lose weight when their blood sugars are not controlled. But then once we get their blood sugars down, we get them stable, they actually gain a few more pounds. You're frequently thirsty. There again goes back to all of that peeing you're doing. If you're constantly going to the restroom, peeing out sugar, peeing out fluid, then you get dehydrated. You feel like you need to drink some more. Extreme fatigue. I think we've all been there too, where we've eaten, a lot of carbs. 15, 20 minutes later, what do we want to do? Take a nap. It's just a sugar overload. Slow healing wounds. This happens particularly in people that have uncontrolled diabetes. So I'll kind of think of sugar. If it has nowhere to go, if it's not going into the cells and it's hanging out in the blood vessels, then eventually it, as Dr. Dawson said, it will clog up those arteries and it makes that blood move really, really slow, kind of like syrup. And so if the blood is moving so slow that it can't even get to the wound, then you're going to have some slow healing wounds that ultimately can happen. And then recurrent infections. I've had patients come in where they weren't necessarily diagnosed with diabetes yet. They're having frequent yeast infections, women in particular, end up doing lab work and come to find out they have type 2 diabetes. Yeast and bacteria like sugar. So if you have an abundance of that in your body and your blood sugars are not controlled, then you're going to be more likely to have frequent infections. Blurred vision, another thing, blurred vision occurs because of dehydration. And a lot of times when your blood sugars are elevated, it causes dehydration and then you get the blurred vision. And then lastly, one of the symptoms is weight loss. And as I explained, your body's trying to get rid of that extra sugar. And so you're peeing out a lot of calories, fluid, and glucose, and it can cause that initial weight loss. So how do we diagnose diabetes? Typically through a blood test. The most common is probably the hemoglobin A1C, and it is a 3-month average of your blood sugars. It's basically looking at how much glucose is attached to those red blood cells. And so in order to diagnose someone with diabetes, you have to have an A1C greater than 6.5% on 2 separate occasions. Prediabetes is going to be a step right below that, 5.7 to 6.4%, and then normal is less than 5%. We can also diagnose diabetes based off of a fasting glucose. So as I mentioned in the previous slide, if your blood sugars are greater than 126 on 2 separate occasions, then yes, definitely we can diagnose you with diabetes type 2. 100 to 125 is going to put you in the prediabetes range. And then when you wake up in the morning, if you do not have diabetes, your blood sugar should be less than, or if you have normal glucoses, it should be less than 99. And then an oral glucose tolerance test. We typically do that in pregnant women when we're testing for gestational diabetes. So we give them a sugary drink, usually it's around 75 grams of carbohydrate, and we check their blood sugar 1 to 2 hours afterwards to see how it responds to that sugar load. And typically, if it's greater than 200, it's diagnostic for diabetes, or prediabetes of 140 to 199. And in the case of pregnancy, they would, say that you have gestational diabetes, which is a risk factor for developing type 2 diabetes later. So as I mentioned at the first slide, if no intervention is if no intervention occurs with somebody that has pre-diabetes, so if no lifestyle changes occur, if you don't start becoming physically active or modifying your diet, then many people with pre-diabetes will go on to develop type 2 diabetes within 5 years. So it's very, very important that, our patients with prediabetes, that we go in and start providing that education and really encouraging them to make those lifestyle changes in hopes that they will eventually prevent getting diabetes. So this is a neat exercise, and all you need is a hand. And it essentially will assess your risk of type 2 diabetes. And how it works is there's 7 questions. And based on the questions is how many fingers you would give yourself. So for example, the first question is, how old are you? If you're less than 40, you wouldn't give yourself any fingers. If you're 40 to 49, you get 1 finger, 50 to 59, 2 fingers, 60 years or older, 3 fingers. So you would answer all of these questions and count based on your fingers. If you end up with more than 5 fingers, then you are at risk for prediabetes, which essentially will put you at risk for type 2 diabetes. So for example, we know that a family history, like if you have a first-degree relative, a mother, a father, a sister, a brother that has diabetes, then you get 1 finger for that. And that certainly is gonna serve as a risk factor for you in the future for developing type 2 diabetes. But I just think that's a neat exercise. You don't necessarily have to do it right now, but it's just a great way to kind of step back and reevaluate whether you're at high risk for type 2 diabetes. So risk reduction. In order to reduce our risk of type 2 diabetes, I would encourage all of us to live a healthy lifestyle. And a healthy lifestyle incorporates good nutrition, weight management, physical activity, and tobacco-free. And the American Heart Association has an initiative that they call Healthy for Good. And what I really like about this initiative is that it really emphasizes the fact that this needs to be a lifelong commitment of change. A lot of times we think of, oh, well, I'm just going to do this really quick, to address my weight issue. But we ultimately need to make a change to live a healthier lifestyle overall. And what they emphasize is 3 different concept areas. Very simple, and simplicity is best to me. So eat smart, move more, and be well. And we're going to talk a little bit about the eat smart and the move more. So my first question is, does your pantry look like this or that? Or maybe it's a combination of both. You know, maybe you have a little bit of the Chips Ahoy tucked away in the back, but then you've also got the beans and the wheat pasta up in the front. But regardless, we know that carbohydrates are our main source of energy. And our body prefers carbs for energy. But we need to make sure that when we are selecting our carbs, that we are selecting foods that do not lead to a very increased postprandial. And what postprandial means is after blood sugar spike. So on the left, if you look at the Coke and the Oreos and the Chips Ahoy and the chips, those are simple sugars. Immediately after you consume that, your blood sugar is going to go up in the next 10 to 15 minutes. And it's going to have a pretty significant impact on it. But over on the right, these foods have more fiber, they're more whole grains. And so those types of foods, they digest much more slowly. So you're not going to have that really significant impact so quickly. And so when we're picking foods, we should make sure that we concentrate more of our efforts on those whole grains and those foods with more fiber. So things like whole wheat pasta, oatmeal, brown rice, quinoa, all of those are much more healthier options than something like Chips Ahoy cookies or Ruffles or Doritos. So eating smart also considers moderation, right? Not what we eat, but maybe how much of it we're eating. And one way that we can exercise moderation is through carb counting. And I do realize that carb counting can be very complicated and it takes time. You have to read the labels, you have to look at the total carbs. Typically with carb counting, men, you know, we don't want them to go over 60 carbs per meal, and women, we want you to stay less than 45 carbs per meal. But it takes planning and you have to add it up. If carb counting is not your thing, then maybe something a little bit more simple like the plate method. So you take your plate, half of it should be vegetable, the other half, 1/4 should be protein, and then 1/4 of it should be starches. Sometimes I'll even encourage patients, you know, instead of doing a regular big size plate, eat off of a saucer, something that's smaller. Because sometimes it's just our mind. We think, oh, well, if we have all of this food on our plate, we have to eat all of that. Well, if you eat on something much smaller, you're already cutting your portions in half. And then keep in mind that even too much of a good thing can be bad as well. I have, you know, patients that come in and they say, well, Alicia, I'm eating more fruit. Isn't that healthy for me? And absolutely it is. I would definitely much prefer you to eat fruit than donuts or cake. But fruit is a natural sugar and it will have an impact on your blood sugar. So it's not okay to eat 2 bananas and a cup of apples. Like you have to learn to eat it in smaller portions. 1 banana is 30 grams of carb. If you had 2 bananas, that's your whole meal right there for a man. And really and truly, if you had 2 bananas for a female, you've already exceeded your 45 carbs. So we just have to be mindful of moderation, everything in moderation. Eating smart also includes healthier choices. So instead of, you know, maybe drinking the tea and the juice and the sodas, I like to do some water with maybe some of the Crystal Light packets that you can add into it. That's going to be much more less carb than having the soda or the juice. And if you're like me, I would prefer to eat my carbohydrates than actually drink them, because your sugary beverages do factor into your total carb. So if you're planning your meal for the night, you have to factor in the, 39 grams of carb that your Coke consists of, which means that you're already about to be over your allotted 45 grams for that meal. So if you just had 1 can of Coke and a slice of toast for dinner, and I know that doesn't go together, you're already over on 45 carbs. So I just recommend that, you skip the sugary beverages. Instead, drink water, drink your Crystal Light. Even, if you're into like Powerade, Zero, Gatorade, do those zero versions instead of the regular versions. You'll get less carb. You'll get, in most cases, you'll get no carb from your sugary beverages. Also, increase your fiber intake. So the recommendation is about 25 grams of fiber. And the reason you want fiber is because it doesn't lead to the increased blood sugar spikes. So if you can increase your fiber intake, it can actually help to lower your blood sugar. And then lastly, eat lean meats. And I know Dr. Dawson had kind of mentioned a little bit about your meat choices. You always want to do fish, chicken, turkey, very limited red meats, just because they have a high fat content in them. And the connection between the fat and the carb is the carbohydrates. Let's just say you eat mashed potatoes and you're going to have a ribeye with it. Well, the mashed potatoes have the carbs. It's going to make your blood sugar go up. But then the ribeye is the fatty piece of meat, and your sugar is going to go up. And then the fatty piece of meat is going to keep your blood sugar elevated. So we always want you to pick choices that are leaner, because then you don't have that lingering elevated blood sugar effect. So now that we've talked a little bit about food and eating smart, we're going to talk about moving more. And the reason that we encourage you to move more is because it helps to prevent health problems. So we know that inactivity promotes type 2 diabetes, essentially. And the reason for that is if you're not moving and you're eating, that glucose is going to break down in the body, and it's just going to hang out, like I mentioned, in the blood vessels. And eventually it's going to start sticking to the lining in the blood vessels. It's going to build up. You're going to get a plaque. And then that's when you have heart attacks and strokes. But if you're moving your body and you're exercising, then your muscles are forced to use that glucose for energy. And so it pulls it out of the blood vessels and into the muscle cells, and then it's burned off. So it is absolutely so important that we move our bodies, that we exercise to prevent hopefully the development of type 2 diabetes. Now then, once you get type 2 diabetes, you have a whole nother list of complications that can occur, such as kidney failure, such as retinopathy that leads to blindness, such as neuropathy that starts to affect the nerves and can lead to other wounds and in the feet and amputations. So it's truly important that we exercise and move our bodies. Annually, about 62,000 Americans begin treatment for kidney failure. And then adults with diabetes are 2 times more likely to have heart disease or stroke. So currently the recommendation, and I know Dr. Dawson has mentioned this as well, is 150 minutes of activity. So if you really break that down within a week's time, that's about 5 days of 30 minutes of exercise. And an activity that you enjoy, make this engaging for yourself. If basketball is not your thing, don't go play basketball. If walking is not your thing, don't do walking. If you like to ride a bicycle, do bicycling. Whatever it is that keeps you engaged, that's the aerobic activity that you need to participate in. And if you can't do 30 minutes all in one time, break it out. Do, 3 10-minute sessions. And then we also encourage that you do some muscle strengthening activity. So you want to do your aerobic activity, but you also want to do something that builds muscle, because muscle is leaner and it burns much faster. Additional ways that we can move. Maybe you want to dance your way into fitness. If you're somebody that likes, music, then turn on the music and start dancing, or take a hip hop class or go salsa dancing. That actually burns a lot of calories. Park further away when you're going places. If you're going shopping, if you're going to Walmart, park in the back of the parking lot. That will force you to actually move and walk towards the building. You'll get more steps in. We encourage you to do short bursts of activity. A lot of people are into their TV shows that they have to watch. When the commercials come on, do jumping jacks until the show comes back on, then sit back down, rest. Commercial comes back on, get back up, do some more activity. find those pockets of opportunity where you can actually incorporate some sort of activity. Get the whole family involved. You know, a lot of times when you have buy-in from your husband, your loved ones, your children, and you do it all together, you're more likely to stay committed to it. So instead of going to the movies for a weekend getaway, maybe, you know, you guys can plan a trip where you go, or you can plan a weekend where you go bicycling on the trace, or you're playing basketball in the front yard, whatever that may be, or whatever that may look like for you, but just get the whole family involved. And then take the stairs instead of the elevator. As the picture says, burn calories, not electricity. So. And then we also want to move more because we want to control our weight, right? And according to the diabetes prevention program, even a modest amount of weight reduction, so 5 to 7%, which is about 10 to 14 pounds for somebody that weighs around 200 pounds, that can actually reduce your risk of developing type 2 diabetes by 50%. So we're not saying that you have to lose 50 pounds, just 10 to 12 pounds, 10 to 14 pounds, just 5 to 7% of your body weight will reduce your risk of developing type 2 diabetes by greater than 50%. That's pretty impressive. And so we have to figure out ways that we can incorporate that physical activity into our daily lives. And in order to burn those calories, you have to have at least a deficit of 500 calories. And there are a lot of calculators online that you can actually access that will kind of tell you how many calories you need just to maintain your normal body function. And then you would subtract the 500 calorie from that, and that'll tell you, you know, how much calories you should consume every day in order to lose a pound per week. But then another way that you can burn calories is just increasing your steps. So the recommendation is about 10,000 steps a day, which is equivalent to about a 5-mile walk. And so that 5-mile walk will equate to an extra 2,500 to 3,000 calories that's burned that week. And 1 pound of fat is about 3,500 calories. So if you even exceeded the 10,000 steps, then you're already on track to at least losing a pound a week. So now we're just going to spend the last couple of minutes talking about obesity. And obesity is defined as excess body fat. It's not to be confused with overweight, because weight does factor in other things such as muscle. There are a lot of athletic people that are technically, based on BMI, overweight, but it's because their body composition is made up of muscle. But obesity occurs over time, and a lot of time it is attached to that stomach area. So individuals with obesity usually will have a waist circumference that is pretty significant. So like in men, greater than 40 inches, and then in females, greater than 35 inches. And you have two types of fat, body fat. So you have the visceral body fat, which covers the internal organs. So that's the body fat inside the stomach. And then you have the subcutaneous body fat. That's the body fat that we usually see. It's the body fat that we can pinch between our fingers, but it's also the body fat that's the hardest to get rid of. It's the stubborn one. And so typically when you start to make lifestyle changes, you're going to lose your visceral body fat first, and then it starts to attack the subcutaneous fat. But you have to actually burn calories to lose the subcutaneous fat. So you have to put some work in to it. You have to start exercising. There are several reasons that obesity can occur. Obviously, food intake, if you're taking in more calories than you're actually expending. Physical inactivity, so we're eating, but we're not remaining active or exercising. Environment, I kind of think of like children living in homes where, you know, I feel like the parents are, you know, to a certain extent feeding that child. And then genetics, a lot of times obesity runs in families. And then medications. For example, I treat a lot of diabetes with insulin. We know that one of the side effects of insulin is weight gain. Steroids in particular, we use that to treat a lot of different conditions, and steroids can actually make you gain a lot of weight. So excess body fat does increase your chances of developing type 2 diabetes. 89.8% of adults with diagnosed diabetes are overweight or they're obese. Some of the treatment options, as we mentioned, make a reasonable weight loss goal. And as I just mentioned, 5 to 7% of your body weight, start there. If you can lose just that, then not only are you treating your diabetes, but you're also potentially decreasing your risk of developing type 2 diabetes. Increase your physical activity. And then bariatric surgery, which a lot of insurance companies nowadays are covering this procedure. And then even the American Diabetes Association, has recommendations about offering bariatric surgery to patients that have type 2 diabetes with a BMI greater than 35. So obesity, in order to diagnose a patient with it, you have to have a BMI greater than 30. So in conclusion, I just want to encourage everyone, now is the time to live your best life. Eat smart, make healthy choices, eat things in moderation, don't overindulge, move more, move your body, engage in that 150 minutes of activity per week. And it may look different for you. I personally enjoy spinning. That's my choice of exercise. I realize that that's not something that everybody enjoys doing, but if walking is your thing, then do that. There's no perfect prescription for how, you do life. And then be well. And that's just a reminder that we have to take care of ourselves, because nobody else will, and we can't take care of our loved ones if we don't take care of ourselves. So it's okay, to set that time aside to exercise. It's okay if you need, a mental break in life, or if you're feeling stressed, to be able to go talk to someone. These are my references, and then any questions?
That was very, very informative. Thank you so much, Dr. Bates. And I will see what questions we have. So Courtney Hunt wants to know, does taking a fiber supplement interfere with your medication?
Especially if you have someone that doesn't, I have patients that are like, no, I don't eat vegetables. I don't eat this. I don't eat that. I will tell them to either do Metamucil, or you can, I think it even comes as a fiber tablet. So you can absolutely take that.
Thank you. Janice wants to know, what about urinating 2 times during the night and a blood sugar check in the morning being 89?
Mm-hmm. So a blood sugar check in the morning of 89 is excellent. Waking up fasting. I guess it just depends. The waking up overnight to go to the restroom, is that something that you normally do? Because some people, do wake up in the middle of the night to go to the restroom. But if it's something that you just started doing frequently, then certainly that may be a cause for further investigation. Like if you've never been one to wake up overnight to go to the restroom, and then all of a sudden you're peeing all night, peeing all day, then I would definitely go and see your primary care provider for more blood work.
Awesome. Okay, I'm trying to see if there's any other questions. Gwen said that was very informative. I agree.
Thank you.
I thought it was very interesting, the hand exercise. I was trying to write down the source that you got that from, because I honestly have never seen that before.
Yeah, I thought it was pretty interesting.
Use
too.
that.
Do really quickly.
There it is. Okay, so do I have prediabetes.org? That's where it came from.
Yes.
That's awesome. I've never seen that before. I think I'm gonna get that and put that in the office. So
Absolutely, because that's something you can easily do with your patients, very quickly while you're in the room.
Yes. Okay. All right. I think we have another question. Actually, Courtney Hunt is just making a comment. She said, it's very difficult to do the right thing, but I understand it's necessary.
I think behavioral change is very tough for anyone. I mean, it takes a lot of consistency and commitment to it. And I think sometimes you have to give yourself grace too, and be like, I'm human. It's okay if you fall off the wagon, just get back on. But yeah, it is. It's tough day in, day out to make those healthy choices, to exercise. I think a lot of times we get busy with life, and things fall by the wayside, but it is, we have to take care of ourselves.
Yes. Well, this was great. I'm trying to see if we have any other questions. Anybody have any questions about prediabetes, diabetes, obesity that we have not answered? I don't think I see any more in the chat, and do not see any on Facebook. So CL Morris says this has been very helpful. I agree. I definitely agree, CL Morris. Very helpful, very informative, a lot of information here. So hopefully everyone has received it and has plans to make changes in their lives. Thank you. All right, so let me share my screen again. Okay, so we've already done the questions and answers. We've had some great questions, great comments from everyone. So that pretty much concludes our program. Want to thank everyone for coming to our program. And just on the screen, you'll see ways that you can help us as an organization to deliver more quality programs for you. It's a way to donate. If you want to, scan the QR code, it'll take you to the link so that you'll be able to donate. We definitely appreciate you. So I'll leave that there for 2 seconds. I want to take this time now to give special thanks to our sponsor, Blue Cross Blue Shield of Louisiana. We definitely appreciate their support in our efforts to deliver this information to you. So we appreciate them for supporting us. Uh-oh, going the wrong way. Okay, now I want to just bring to your attention some upcoming events that we have as an organization. Now, tomorrow night, around this time, 6 o'clock to 7:30, the Health Committee will be putting on another program by a fitness instructor, self-care coach, Ms. Tanya Chapman Griffin. She will talk about self-care strategies and fun exercises that can be performed anywhere to enhance clarity and productivity. You'll gain more knowledge about identifying methods of self-care in mind, body, and spirit that can be applied to daily lives. So this one should be very interesting as well. The link is here. Please register. We would love to see you again tomorrow night. And then the next one is on Mother's Day weekend. It's a Miracle Suite Extravaganza. That's on Saturday, May 7th at the main library. This should be a very fun event. There's a lot of activities for adults and children. There'll be painting and just a lot of fun activities. So if you're available to attend, that is an in-person event and you can register there. Register to attend. So again, I want to thank our presenters, Dr. Desiree Dawson and Dr. Alicia Bates, for spending their evening with us and sharing all of this information with us that I'm sure we're all going to take and incorporate into our lives. And I want to thank everyone else for attending and supporting our programs. We wish that we will see you at our next program in the very near future. I want to thank you and tell you to have a great evening. Good night.